now into tube current modulation, which is going to play a bigger role in a lot of the protocol parameter descriptions as we move forward from here into the chest and the abdomen and pelvis. So we're going to have Mark Supanich do a reprise. Is that how you say it? Another talk on tube current modulation.
The tag team continues. Okay. Again, here are my disclosures. And in this talk, we're going to be going over some of the automatic exposure control fundamentals specifically focused on tube current modulation. Automatic exposure control can encompass, a variety of different things, including tube potential selection. But we're really going to focus here on tube current modulation. Go into some of the fundamentals. Consider some of the potential pitfalls that you might encounter in using tube current modulation, and then look at some vendor-specific implementations and some additional topics for consideration. I again was remiss in this talk in not having screenshots of how to get to that very, very, very important AEPM page for the CT working group on standardization of nomenclature and protocol. Because not only do you have the lexicon there and slides about suggested protocols for the different vendors, but also the CT dose education slides live there. And this will actually be the only interactive portion of this talk. How many folks have seen some sort of email blast announcement about the CT dose education slides? All right, about 50%, not bad. For those of you who hadn't, consider yourself blasted. They are freely available on the AAPM website under that same area. They're hopefully fairly comprehensive set of slides that go over a lot of the different acquisition parameters and stuff like iterative reconstruction and how they affect dose. And so some of the slides I'm going to use in here talking about tube current modulation are actually pulled from those as well, and those are labeled right at the bottom. So you'll be aware of those. But they're an excellent resource for you to refer back to share with the technologists at your institution, to share with radiology residents, with staff radiologists, useful information. So AEC and the different ways that it's implemented are on CT scanners with the aim of meeting a particular image quality along scan length and amongst different patients. So they'll determine the patient attenuation and tailor the scanner output to the patient and to the body region to try and match the desired image quality. That's generally overall what they do. They're especially useful for non-homogeneous scan regions or for body parts that are not uniform in size. I think we saw for the head studies, not a lot of folks are using tube current modulation for that. So the way what we're going to focus here with AEC is really on tube current modulation or dose modulation, and scanners are able to adjust the tube current to achieve the desired image quality or to reduce or increase dose compared to a standard reference for individual patients. And what's really important to remember is that the implementation of these systems varies dramatically from vendor to vendor, and it can even vary from software version to software version in the same vendor. So that's very important to remember. What applies on your Siemens system may not apply to your Philips system, and what's on your GE might not apply to your Siemens. So very important to remember, especially if you're in a practice with multiple types of scanners. So these are some of the AEPM CT dose slides. So general overview here saying AEC will adapt tube current or tube potential to achieve a specified image quality. I don't think we're able to hammer this point here home enough in this talk. Is in this actually throughout this entire summit, that centering of the patient in the gantry is vital for image quality, for your reconstructions, and it's incredibly vital for the proper functioning of automatic exposure control systems. And we'll get more in depth into that, but I really want to reiterate that if there's, maybe I'm remiss in saying this, but I think if we all went back to our institutions and really, really focused on making sure the patient was at ISO center, I think a lot of variability in dose for like same-size patient, or changes in the dose for a patient from scan to scan, or change in the CTDI vol from scan to scan would probably go away. I think making sure the patient is centered is probably some really low-hanging fruit. It's not always easy to check, because you got to go through and look at all the different scouts and see, AP versus lateral. But there are maybe some ways that you can get, that the technologist can identify after the fact. Oh, you know what, we didn't center this patient that well. Flag it for review, that kind of stuff. So maybe something to take home and consider. And for those institutions that are already doing it, excellent, kudos. So the use of AEC in its various forms may end up increasing or decreasing the CTDI vol for a study for a particular patient, depending on the patient size and the imaged area and what kind of image quality we need. And so the first really acquisition scan parameter that comes into play when you're talking about tube current modulation here, so we're going to go from talking about general AEC systems to tube current modulation, is the image quality reference parameter. And that's the parameter that's set by the user or the radiologist in developing the protocol that defines the desired level of image quality. And if we change the image quality reference parameter, generally that will affect the CTDI vol. However, that effect on the CTDI vol is vendor and scanner dependent. So that's something to definitely keep in mind. So setting the parameter, though, generally for increased image quality, whatever that change may be, and we'll get to that for each of the vendors later on, setting the parameter for increased image quality will result in an increased CTDI vol, and setting the parameter for decreased image quality will generally result in less CTDI vol, decreased CTDI vol, holding everything else constant for the same patient. This is if you were to scan the same patient and change that image quality reference parameter. The next acquisition scan parameter or feature of AEC to consider, and has already been mentioned, is angular tube current modulation. And so angular tube current modulation, just as a review, will modulate and adjust the tube current as the X-ray tube rotates around the patient to compensate for attenuation changes with view angle. The intent of angular tube current modulation is to attempt to deliver the same number of photons to the detector at all view angles. And again, the use of this may end up increasing or decreasing the CTDI vol for a patient, depending on their size and the body region that you're scanning. There's no, tried and true. If I have this on, it, increases or decreases dose. It's dependent on what you're scanning and who the patient is. So just graphically here to show what might happen if you have turned on angular tube current modulation. Instead of having, for this instance, say a flat MA across here, you're actually at the AP view. You're going to have, let's call this 50 MA, and then in the lateral view, you're going to have 100 MA, and then the PA view, you're going to have 50 MA again, and then for this other lateral view, you're going to be up to 100 MA. And that's because the attenuation through it probably wouldn't be this extreme because this is a fairly circular object, but the attenuation in the AP direction is less than that in the lateral direction. So the tube current is reduced to try and match the number of photons hitting the detector. Here's a physical measurement in a CIRS phantom, which has a larger dimension in the lateral way than in the AP dimension, and this is a real-time dose rate measurement placed at the 12 o'clock position and the 3 o'clock position, and you can see a slight difference in the peak dose rate at the 12 o'clock position as compared to the 3 o'clock position. As you go to more extreme geometries, you would expect the difference in the peak dose rate to be more significant. But unfortunately, I only had access to this one particular phantom for this visualization. The next image quality, the next acquisition scan parameter to consider in this is longitudinal tube current modulation. And this is a feature that will, again, adjust the tube current along the length or the longitudinal or the Z or the transaxial, whatever we want to call the length of the patient, their height. This will adjust the tube current as the patient's attenuation in that direction changes. The CT localizer radiograph is used to estimate the patient attenuation or size, and that information is used to adjust the tube current. And the use of longitudinal tube current modulation, again, it may, for a particular patient, it may increase or decrease the CTDI vol compared to not using it, depending on the patient size. All right, and so here's a view, just again, of how the tube current might change as you go from going through the shoulders, down through the thorax, and back through the abdomen. And so you're going to have more tube current as you're going through the more highly attenuating shoulder and through the abdomen than compared through the thorax. Here's an example on a combination of phantoms that were scanned showing in the neck, low tube current, increasing through the shoulders, then coming back down through the chest, increasing in the abdomen, and then kind of flat here where there's no change in attenuation along this length. Again, it's not instantaneous. It averages out because because your beam is not infinitesimally small. It's got some size to it, and you may have different parts of the anatomy in your collimation as you're going through. So the combination of angular and longitudinal tube current modulation is also something to consider. A lot of systems will allow you to either have one on, well, usually longitudinal on and not angular on, but you may also have both on at the same time. And so the combination of these two will, again, as we've seen before, adjust both kind of the gross tube current as you're going along the length of the patient and also adjust it angularly. And it has, again, the same relationship with CTDI vol. Using it may increase or decrease the CTDI vol compared to not using it, depending on the patient size. I think I'm saying that a lot, but that's definitely something to keep in mind, is that using these features doesn't mean that you're decreasing the CTDI vol that you're using for these studies. It could mean you're increasing the CTDI vol or decreasing it, or it could be the same as what you're using without it if it's a perfectly homogeneous patient. But that's really important to remember, is it's not meant to reduce radiation dose, but it's meant to maintain image quality through the patient and amongst patients. And so here's this view. You combine the angular and the longitudinal tube current modulation, and you end up with a gross change along the longitudinal, and then the angular changes as well. So that's kind of an overview of the relevant different acquisition scan parameters that are used in AEC and tube current modulation. And so here we're going to spend some time talking about some of the pitfalls that you might encounter in either setting up your systems to use tube current modulation or in the use of them. And so the first pitfall, I think, not surprisingly, it's if you've been paying attention, is our old friend patient centering. All kinds of exciting things can happen with patient centering. And one side note, actually, before I get into patient centering and tube current modulation, especially given Mike's discussion of the dose index registry earlier, and that SSDE can be included if you're sending along your localizer radiograph. One thing to note is if you're sending in localizer radiographs with, say, every patient not at isocenter. Let's say every patient's about 5 centimeters low. The measurement that's going to be used to estimate the size of that patient is going to underestimate the size of every single patient, and then you'll get an overestimation of your SSDE, which will be played out in your dose index registry data. So if you want your most accurate SSDE information for the dose index registry, and you want your tube current modulation to function properly, and you want the dose distribution throughout the patient to be proper, and you want your recon field of views to make sense, please center the patient. I'm sure there's another reason or two out there. Maybe we'll get to those later. But so here's a little example. I took this chest phantom, Chester as we call him, and placed him. This is located at isocenter in this position, raised 4 centimeters here and lowered 4 centimeters here. All right, and had the exact same tube current modulation settings for these scans after doing each one of these localizer radiographs. So the ideal situation is the patient size and attenuation, which are used to determine how your tube current is going to modulate. You're at isocenter. The system assumes the patient is at isocenter, and everything is based off of that. Now, if you position them above or below isocenter, that will affect the calculation of the apparent attenuation or the apparent size, however the specific vendor does it, and that can affect the implementation of tube current modulation. Another thing to keep in mind is that if you have the patient not centered, you've got them centered properly with height, but you've got them shifted to one side of the table or the other, that's going to end up affecting your image quality and the implementation of the tube current modulation as well, because you'll end up with a non-isotropic dose distribution from one side to the other, additional issues with that. So centering both in the table and at height is very important. And I did these scans on a Philips Brilliant 64 and looked at the CTDI vol for the chest and in the shoulders. For it's centered for the table raised 4 centimeters and the table lowered 4 centimeters. You see some change here, but not actually huge significance. I was like, that's something, but that's not really all that much. But thankfully, Diana Cody and the team at MD Anderson were kind enough to share the following set of slides with me, which actually show some much more, a lot more significant changes with patient centering. And again, it's everything in this is vendor dependent. So this again shows what an apparent size can look like with a patient properly centered at isocenter versus a patient below isocenter. So you can see the apparent width here is less, and above isocenter, and so magnified. This is fundamental X-ray imaging concepts of magnification. So what her team did was go through and set the table at a bunch of different positions, acquire the localizer radiographs, and plan the scans on a number of different vendors, and recorded a number of the parameters, and planned the scans with the different table heights, and acquired what the expected CTDI vol was going to be for these systems. And so you can see with extremes down to, if you've got the table 15 centimeters below isocenter, the predicted change in CTDI vol is over 40% below. Same thing as if you go up on some scanners. Other scanners were down here. Differences of 10 centimeters in table height can have impacts of 20% on what the expected CTDI vol is going to be used for these systems. So very important to remember that how you center the patient is going to change the predicted and the actual implementation of the tube current modulation. I think there's lots of opportunity to make sure that we're working right here where everything's nice and tight, to make sure we're doing that when we're scanning the patients. So to use tube current modulation, it is very, very important that the patient be centered. Now, one of the things, I think, one of the challenges is, all right, I'm doing a chest, abdomen, pelvis. Where do I center the patient? And this is a patient with you could have a barrel-chested patient or a pot-bellied patient, And you're centering for those two. You could center in the chest on the barrel-chested patient, and then all of a sudden the abdomen is well below isocenter. And for the larger abdomen patient, you could center on the abdomen, and then your chest is well below isocenter. I honestly don't have any recommendations on what to do in that situation. Maybe right in the middle. I don't know. Maybe that's the right solution. So you minimize, the deviation over the whole thing. But that's definitely, something I hadn't even thought about. I think before, I can't remember who I had a conversation with this about recently, but I hadn't even thought about that. Actually, I think I was teaching some tech students just the other day, and they were like, "Wait, what about if they're drastically different in AP size in these two different regions?" You go with the liver? Okay. All right. We got one vote for the liver. I think that makes a lot of sense, especially if I think we have seen that the changes through the thorax, especially the angular tube current modulation, maybe through the thorax, might not be changing as much. So maybe that also plays into making sense to use it for the liver. But definitely something to keep in mind, and something to ask everyone at your practice is, okay, you're doing a chest, abdomen, and pelvis, where are you centering? And to make sure it's consistent. Have a practice, have a plan throughout your institution. Another significant pitfall or problem with the implementation of tube current modulation can happen if you're trying to scan outside the region of the localizer. And this can certainly happen in a number of instances. It could be, maybe you just missed a little bit of the liver as you were doing the localizer planning. Or maybe you did a scan, the radiologist saw it, and the patient was still on the table and said, actually, no, I want you to acquire, I need you to acquire some, somewhere further down the patient. Maybe they saw it was a chest, maybe they saw something, at the top of the liver or something, and it's like, okay, scan through, I want you to also do a scan through the liver. But you didn't acquire a localizer radiograph through the liver. And then you go ahead and plan the scan. A lot of the systems will actually let you plan a scan and do a scan without having that localizer information ready. Some systems will warn you and say, hey, there's not any information here. Are you sure you want to do this? But others will just let you go through, whether it be going only a couple centimeters past the end of the scan or scanning an entirely new body region. And the reason this is a problem is because tube current modulation uses the information from the localizer radiograph. And there are a number of possible outcomes if you scan outside of it. One is that the tube current could go to a maximum setting, the maximum setting that you've got for that AEC setup. It could go to the minimum for that setup. It could stay at what it was at the last known point of the localizer, or it could go to whatever manual setting you've got for those systems. And I've got a couple of examples here, and this just shows, again, this phantom combination here, the chest and the abdomen, and this whole thing was scanned, and then the localizer was just acquired just with the chest and the, I guess that's the liver too. So this is kind of into the abdomen, but the combination of these two, so full localizer radiograph, partial, and did this on a number of different scanners. Did this on a Philips system, and this is, again, all these images are in this portion here, right about down here. So on the Philips system with the full localizer radiograph, right here, these systems can give you a virtual slice CTDI vol that's in a DICOM object. It's not really a CTDI vol since it's, not the proper definition, but it can give you an idea of what the tube output was at this position. So right here at this slice with the localizer radiograph used, the estimate of CTDI vol was 7.3. For the scan without the localizer, it went to 19.35 milligray. Obviously a lot better image quality here. But this is a really small phantom and probably not needed. So again, an extreme example where you're going way past where the localizer radiograph is, but that might actually happen occasionally in practice. This localizer radiograph, I actually included another phantom. This was kind of a pelvis phantom. And so again, same thing though, scanning all the way through for the localizer radiograph. Oops. This is with the localizer radiograph covering all the anatomy of interest, and this is with it cutting off early. and this was on the GE Lightspeed 16. And for this one, what ended up happening was the tube current went to the minimum setting for the plan. So you set the maximum and minimum MA on a GE for that tube current modulation. And so for this, it went to the minimum tube current. For the Siemens system, it ended up using the tube current at the kind of the last known location, its last best guess for what the attenuation was as it went through the rest of it. Which was, not bad for this situation, but if you were then all of a sudden going through the pelvis, you would have all kinds of image quality issues. Here's an example actually from a patient on the Toshiba, since I wasn't able to actually get access to the scanner to do the Phantom. And my understanding of what it did on the Toshiba system is that it went to the default manual setting. So you could turn tube current modulation on or off, and if it's off, there's a default manual setting. So actually in this region, which is actually well below where the localizer radiograph actually cut off, the tube current went to its default setting, which was 200 MA. Whereas up here was actually using tube current modulation. So that's a significant pitfall, and again, I think a lot of the vendors deal with it differently, and it's something to be very important and aware of. And maybe make sure especially if you're going to scan well outside where the original localizer was, acquire another Scout and plan off of that so that the tube current modulation can act as it's needed to. And that you get the right image quality for the imaging task. Another very, very significant potential pitfall in implementation is if you change the patient orientation in the middle of a scan and don't acquire another localizer radiograph. I know this has happened at my institution before. It's not incredibly common, I think, but you could certainly... maybe some virtual colonoscopies, I think you would acquire one prone and one supine, for instance, and if you don't acquire another radiograph and you tell the system that you've switched orientations, it has no idea what to do because it doesn't know where things are. The assumptions that it has have gone out the window. And so that can have an effect on how the tube current modulation is implemented as well. So the systems, they just have to assume that the localizer is no longer valid. Some systems will go to the default manual setting for that protocol if there is one. Others will demand that you procure a new localizer before proceeding. Other systems I've seen have set the tube current to the maximum just because they want to make sure it's a diagnostic study. I guess I'm giving a little too much... I'm making the systems like they're alive. There's a word for that, but I can't think of it right now. But the way they're designed is that they'll go to the maximum. Some will go to the manual setting. So again, very important to remember. I think a lot of this comes actually back to the localizer radiograph. It's a very, very important tool, and it's your friend. It's our friend. So we should make sure we treat it right and get good ones and appropriate ones for what we're going to be acquiring. Another pitfall and another area that we don't think about a lot is that the reference parameter, that image quality reference parameter that is used to determine how the tube current modulation is going to go, that can actually be dependent upon your acquisition image thickness. This doesn't necessarily apply for all vendors, but it does apply for some vendors. And it's very important to keep in mind is that if you change your acquisition image thickness or your nominal collimation or detector configuration, whatever you want to call it, your reference parameter might automatically change, it might not change. But one example of what this means is, say, for instance, at our institution on our GE VCT, for an abdomen pelvis study, we've got the protocol set up to acquire at 32 by 1.25 for the first phase through the abdomen pelvis. We recon those at 3.75 millimeters for the radiologist to read. But the 1.25s are the acquisition image thickness, and that's what we use to do coronal and sagittal reformats. So the noise index for that particular setting is based on the acquisition image thickness of 1.25 millimeters. Now for abdomen pelvis with contrast, then we have a delayed phase. And for those, we're not going to do any coronal and sagittal reformat, so say let's save some space. Let's do those at 3.75 millimeters. Okay. That has a different image quality reference parameter that's needed for that 3.75 acquisition image thickness versus the 1.25 millimeter image thickness. So there's a noise index for GE and there's a reference noise index. And the reference noise index changes with the acquisition image thickness. And then you can change your noise index off of that reference noise index. I'll get into this more when I get into the vendor-specific implementations. But the important thing to remember is that you can have two different noise indices or two different image quality reference parameters depending upon your acquisition image thickness. And we ran into this because we made some changes to the protocol and we actually made changes to the noise index and changed the noise index. We saw it as like, this is weird. The noise index for the second phase is different than the first phase. So we set them the same, not realizing that the reference noise index and the acquisition image thicknesses were different. And then all of a sudden we saw, why is the delayed phase such lousy image quality? It's got the same noise index as the first phase. Different acquisition image thickness, different behavior, and different implementation of the tube current modulation. So very important to remember. To the best of my understanding, but don't take my word for it, make sure you read your manual closely on tube current modulation and talk to your application specialists. To the best of my understanding, if you change the acquisition image thickness on Philips and Siemens systems, it won't change the image quality reference parameter. I'm not positive, or I didn't have enough information on the other manufacturers to know for sure. But luckily, at lunch tomorrow and at breakfast tomorrow, at lunch and breakfast tomorrow morning, you're going to be able to sit with representatives from each of the vendors. And this is a question you can ask them. And I bet you they're all going to make sure they have the answers from home base tonight for this, to know what happens if you change the acquisition image thickness. So they'll be prepared, I'm sure, so you can ask them. So it's really important to keep that in mind, and that that one little change is like, I don't need these thin because I'm not going to use them. That can have a significant impact on how the images are acquired. Some systems also allow you to set a minimum and maximum value for the tube current, the max and min to what the tube current can modulate to during the acquisition. And those limitations can be helpful in some situations. Say, for instance, if you're scanning a patient with a metal prosthesis or who's got some metal in their spine or that kind of stuff, and you know that as you're going to scan through it because there's something above or below that you need to see, but as you scan through that the attenuation is really high there and it's just going to really ramp up the tube current, but you're not going to see anything good anyways. So in those cases, limiting the maximum tube current, might make sense. But it can also mean that if you set your maximum tube current too low, and you get, a really obese patient in, that your study might be limited because the tube current has maxed out. Again, same thing with minimums. I think as you get to really small patients, some of the tube current modulation can get more difficult. Some vendors don't recommend implementing tube current modulation on pediatric patients just because the small size and can make things difficult. So you can also set a minimum if you say you could go down to a really thin waist, for instance, and you don't want it to go below 100 MA. You've seen some examples. If it goes too low, things just don't work right. So you can set minimums as well. And at least GE and Toshiba do allow you to set minimum and maximum values for the tube current that can be used under a scan using tube current modulation. But it's important to make sure you think about what these values are and how they could affect things. Again, at our institution, we We were changing some radiation. We were changing some image quality reference parameters on the GE system to see if we could bring our abdomen doses down and still have good diagnostic quality. And so we brought the noise index down, and we also brought the minimum tube current down. And our radiologists actually found for the large patients, the reduced noise index, the increased noise index, and the lower dose. For the large patients, the image quality was great. But actually, the thin patients, the image quality was not good. Same noise index, but for some reason with the smaller patients, it didn't work quite the same. And by bringing down that tube current, that minimum tube current, we actually made it even worse. A lot of them would have, minned out. Instead, we brought it lower, and they were approaching non-diagnostic, so we bumped it back up. So just things to keep in mind. They're not necessarily linear or even power law systems. They're complex, and great care must be taken to set things up. Another thing, how you acquire, in what order you acquire localizers, and what localizer you actually plan off of can have an impact on how tube current modulation is implemented. Let's say you acquired a localizer and then noticed that the patient still had a belt on. You had them take their belt off and then acquired another localizer. But let's say you planned your scans off the localizer with the belt on it. Some systems might use that. Some might use the last localizer. So I think at the very least it's important to always plan off of the most accurate localizer and make sure that that's the last one that was acquired. Don't go back and say, don't acquire one localizer, acquire another, and then say, oh, actually I want to plan off the old one. Make sure it's the last and the best localizer, I think, to make sure that your tube current modulation is going to be implemented properly. And really, since each one of those is a little bit extra radiation dose, always try to make sure it's the best one the first time. Another pitfall, and this really isn't so much in scanning systems, but this is in evaluating whether or not the AEC systems and the tube current modulation is working well after the fact, is that pretty much none of these parameters get displayed on PACS as overlays. And the reason they can't be displayed on PACS as overlays is because a lot of them are not stored in standard DICOM fields. A lot of them are private DICOM data, and that means that a lot of PACS systems won't pull in data from non-standard fields to include an overlay. So there's really no way that I know of I'd love to be corrected, no way I know of on any system to say pull in what noise index was actually used to scan a patient, or what the reference MAS was, or the mass per slice. There's no way for the radiologist reading to know for sure that the protocol was actually followed unless they go and open up the data, and open up the metadata, and go and find the proper private field to find that in. I don't know of any PACS systems that do that. And so really what that means is a lot of us could be flying blind to whether or not the right parameters are set for the tube current modulation. Right? I don't know how, but there are ghosts in the machines, and some, or they'll tell you I don't know how this parameter got changed, but it got changed, and whether it gets blamed, on the service guy coming in, or it was just changed for one patient and never changed back. Things do end up changing, and we could be completely unaware of them because these parameters aren't available for easy review. So I think that really speaks to the importance of frequently reviewing the protocols on the scanners, and for the CT operators to make sure that what the parameters are set to when you're about to scan match what the actual master protocol is. Not just hit the button and scan, but confirm that it matches what the master protocol is. So that's quite important. Hopefully, as we move forward and more stuff becomes standardized, some of these will become proper DICOM fields, and we would be able to see them as overlays and track them. But today is not that day. Okay. We're going to move now into how some of the different vendors implement tube current modulation. So first, again, going in alphabetical order here. GE, their image quality reference parameter is called the noise index. Increasing the noise index will typically decrease the CTDI vol for the same patient. Decreasing the noise index will typically increase the CTDI vol. The noise index is generally about the standard deviation of the Hounsfield units in a piece of plastic scanned with those settings. So that's what that is. As I mentioned, there's the additional parameter, the reference noise index, which is kind of the default system setting for that image acquisition thickness. So the reference noise index will change as you change acquisition image thickness. And then from that reference noise index, you can go in steps to change there are dose steps, or you can just set a particular noise index. But that's based off of the reference noise index. So even the same noise index doesn't necessarily mean it's the same tube current modulation, because your reference noise index might be different because of that acquisition image thickness. Longitudinal tube current modulation is typically called auto-MA. Angular and longitudinal together are called smart MA, and GE does allow you to set minimum and maximum tube current settings, and you can use tube current modulation on head protocols for GE systems. Here's just for all of these, for a number of these systems, I scanned those phantoms and changed a number of the parameters, generally the image quality reference parameter, kept everything else the same just to see what the CTDI vol did and what the standard deviation of the noise is. And I'll go through these generally pretty quickly for each vendor because they're available on the slides, and there's not so much fun to be had by me just reading out numbers, which you can see. But these are the acquisition parameters. This was on the Lightspeed 16 with the 32 by. Obviously, this was not on a Lightspeed 16. This was on the VCT. Sorry, my bad. Or actually, no, it was on a Lightspeed 16, but the acquisition parameters were probably instead 16 by 1.25 and not 32 by 1.25. So I changed noise index here from 11 to 15 to 17.8, and the resulting change, you can see, as the noise index went up, the CTDI vol went down and the noise increased. Okay. Pretty straightforward. Hitachi's parameters, what their acquisition scan parameters are known as, they call their image quality reference parameter the SD, or standard deviation. If you increase it, it'll increase the noise and generally decrease the CTDI vol. Again, everything else held constant. And the converse is true. And their combination of angular and longitudinal tube current modulation is called IntelliEC. And I don't have any images to show for them. Newsoft, their tube current modulation program is called DoseRight, and their image quality reference parameter is known as the dose save level. If you increase the dose save level, it will decrease the image noise and increase CTDI vol. Decreasing it will decrease the CTDI vol. Their angular tube current modulation is known as DOM, or dose modulation. Longitudinal tube current modulation is ACS, or automatic current selection, and you just combine the two acronyms together to know what it's called for the combination of them. I've got two slides for Philips here, since they had a fairly recent software change that changed what a number of their acquisition parameters were called. So, my understanding, this is their latest software version that's shipping, and so it's called DoseRight. Their image quality reference parameter is the DoseRight index. If you increase it, it will increase the CTDI vol, and if you decrease it, it will decrease the CTDI vol. They call their angular tube current modulation 3D modulation and longitudinal Z modulation. And the two combined are Z modulation and 3D modulation. Some of the older Philips softwares, I think, at least that were valid with release 2.6 or so, the image quality reference parameter for these is actually called mass per slice. And if you increase the mass per slice, it will increase the CTDI vol. So that's the same as the DoseRight index. If you increase the mass per slice or the DoseRight index on Philips, it'll increase the CTDI vol. Again, everything else held constant. And if you decrease it, it'll decrease the CTDI vol. Now, for Philips, at least I know for the mass per slice, that's the mass per slice that you set. That determines what the image quality is going to be like in a reference patient. Okay, so you set that, and that kind of sets what compared to the reference patient and what your current patient looks like. It'll change stuff based on the comparison of the reference patient to have the same noise as that set mass per slice. Angular tube current modulation is called DDOM, and longitudinal ZDOM. The two combined together are ZDOM and DDOM. Angular tube current modulation, to the best of my knowledge, at least on this software system, Angular is not available for head protocols on this Philips system. And you can also, after the localizer, so for Philips systems, you set an MAS per slice, and that's kind of your gross general image quality. Once they've done the localizer, the estimate of the mean mass per slice is then generally available. So you can get an idea about what the average effective tube current time product is going to be over the length of the scan. So you can see if it's going to be above or below. And it's important to remember that mass per slice that you set isn't a maximum. It's just kind of an indication of what the image quality is going to be like, what image quality you want for that reference person. So the mass per slice that you actually use could be significantly higher or significantly lower than that MAS per slice. And one particular thing to note with these Philips systems, and it is indicated in the manual, but I don't know how widely known it is. If you go in and change the MAS per slice setting, so let's say you're set at 300 MAS per slice, and you've done a localizer, and you're at 300 MAS per slice. If you change that 300 MAS per slice to something else, the system learns from that and starts to use that information in the future to say, oh, actually, they want different image quality than what I was going to give them based on the reference phantom. So you never want to change this MAS per slice when you've got tube current modulation enabled after you've done a localizer. Very important thing to remember, because that can end up affecting the future behavior of the system. Again, here's a scan example, same kind of setup. This one actually was 32 by 1.25 detector configuration. So changing the MAS per slice, going up from 200 to 300 to 400, seeing changes in the standard deviation of the Hounsfield units in this uniform region, and seeing the average CTDI vol for the scan increasing as you increase mass per slice. Siemens, their system is called CareDos 4D. There's image quality reference parameter is image quality reference MAS. Again, with this system, you set that. It's basically going to give you, based on that setting, it gives you a desired image quality in a reference kind of, quote-unquote standard person, who we've learned is actually pretty small. And again, so you can definitely have your MAS go way above this image quality reference mass, or way below if you're out in Los Angeles or something like that. Not so much in Detroit. So increasing that will increase CTDI vol, and decreasing it will decrease CTDI vol. They call their angular tube current modulation angular tube current modulation. Their longitudinal is called axial, and the combination of the two is called CareDos 4D. Similar to the Philips system, only longitudinal tube current modulation is available for head protocols. And again, you can also get an estimate of what the mass is going to be after the localizer. Again, some Siemens scans examples, going from 200 to 300 to 400 quality reference mass. We saw increases in the CTDI vol and decreases in the standard deviation of the Hounsfield units. Toshiba's system is called Sure Exposure 3D, and their image quality reference parameter is SD. If you increase SD, it will decrease CTDI vol. Decreasing it will increase CTDI vol. They call angular tube current modulation XY modulation. To my understanding, the longitudinal tube current modulation is always on. And the combination of the two is called Sure Exposure 3D. And they as well allow you to set maximum and minimum tube current settings. One thing to note, so I mentioned this for the Philips already, but one thing to note with the Siemens systems is that, and this is indicated in their manuals, is you can actually go in and adjust how the tube current will change based on patient attenuation. So you can actually go in probably with the assistance of applications or with the service engineer, is you can go in and say, you know what, okay, even though my patient size is increasing in attenuation, I don't want to use the same slope for that increase, say that I did in the middle of the range. Let's say for the larger patients, I'm willing to let that slope go down a little bit to not increase the tube current quite as much, even though patient attenuation is going way up. And then you might also say, you know, similarly, as patient attenuation goes down, I actually want to increase my tube current. I want to increase the change in the tube current more down there because smaller patients, smaller anatomy, you might need different noise characteristics down there. So that's one important thing to keep in mind with those. Here's a quick little summary of generally nothing. I made sure to have about here. These are all estimates. But about what you can expect when you change the image quality reference parameter by 25%. What really the key is here to see that changing the image quality reference parameter up in one system compared to another system has different things. GE, Hitachi, and Toshiba, if you increase the image quality reference parameter, your CTDI vol will go down. The other systems, if you increase the image quality reference parameter, your CTDI vol goes up. Here's an example of what happened at our institution. We changed our image quality reference parameter on our Philips system because we got our dose index registry data back, and we're like, oh, we're above the mean. Let's see what we can do here. So the radiologist and I, we made a change, didn't tell any of the other radiologists. This was the division head, so it was okay. And no one complained. And we took it down, in 10% steps. So we took it down from 40 mass per slice, and we recon at 3.75 here. We took it down from 400 mass per slice down to 300 mass per slice. And so you can see here, first of all, we have many fewer that are maxing out at the maximum tube potential. And our mean CTDI vol for the studies has gone down from 17 to 15. Maybe not quite 25%, but there is. Changing this image quality reference parameter definitely did, and this is over 1,000 patients in each instance. So it definitely did change the behavior of the system. We also did the same thing on the GE. This is when we found out that we were going too low with the minimum tube current. And again, here we changed the noise index from 24 at the image acquisition thickness of 1.25 millimeters. We went from 24 to 30 and brought the minimum tube current down. So again, we had fewer maxing out at our maximum tube current that we had set, but we probably had, we started to have some not so great scans down here, and our CTDI vol went from 15 down to 12. And our radiologist was like, you know what, actually, okay, I had already pretty well optimized the VCT. Let's go back to this setting. And now this is actually where our Philips is at. So those two scanners are matched now pretty well for CTDI vol and image quality. So some additional topics for consideration here. For some systems, if you use the same image quality reference parameter, you're not necessarily going to get exactly the same image quality. Adults of varying body habitus may produce different image quality results. And so I already kind of touched on this with the Siemens, where with the Siemens systems, you can change how the tube current behaves. And this kind of also ties into what our personal experience mentioned with the GE, is even though the noise index was the same, the radiologist found the image quality for the smaller patients to be unsatisfactory, where it was satisfactory for the larger patients. So this slide is courtesy of John Rong at MD Anderson, and this shows for different noise indices, different sized phantoms, and what the actual measured standard deviation of the Hounsfield units is. And so you can see here, for these large patients, all right, so let's place first of all, let's focus here. Phantoms of kind of medium size, the behavior at the same noise index is pretty consistent, right? you've got standard deviations in noise that are all about in the same ballpark. But all of a sudden we go to this large phantom, and even though we're at a noise index here of 26, my noise in this image is at 18, and my noise in these smaller patients is at 25 to 30. So depending on body habitus, the systems may not actually match image quality across all patients. So we started out talking like that's the goal of them, but actually there are caveats to that, and it's important to keep that in mind. On a broad overview level, they do a really good job of matching image quality across patients and through body parts. But there are caveats to it, and it's really important to keep those in mind and be aware of what they are, and ask your vendor and your application specialist what those caveats are and how, if you don't want these things to happen, you can avoid them. But you know what? Maybe you do want these things to happen for the really large patients. Maybe this makes sense. It's up to you. And so that kind of ties into do pediatric patients a different size require different image quality? If I'm imaging a 2-year-old and I'm trying to see some anatomy in a 2-year-old, it's smaller than what it is in a 10-year-old, right? So our ability to see something is dependent not only on the noise in the image but also on the size of the object and its contrast. So you may want, if you're using tube current modulation and AEC for pediatric patients, you may want to consider having different image quality reference parameters for those pediatric patients. And just here's an example. One of these are patients of the same water equivalent diameter. Both were done to rule out appendicitis, right? One was done using the adult tube current modulation, and the CTDI vol on this was 20.8 milligray. And the other one was done using at our institution we use fixed protocols for pediatric patients, just because of the number of different scanners that we have, the number of different types of scanners we have. It just made sense to try and do this. So this one was done at 6.1 milligray. Now the image thickness is a little bit different, but not dramatically so. But for the imaging task to rule out the appendicitis, this image our radiologist found certainly of acceptable diagnostic quality, whereas this is what they would have received as an adult for, if they were, well, this is what they did receive with the adult protocol. So things to keep in mind, that there may be considerations with pediatric protocols. Another topic to consider, should AEC or tube current modulation be used for extremely large patients? Some systems don't allow you to have a maximum tube current modulation. Our CTDI vol values in the body, you're limited by the total tube power, but some of the tubes that are available are actually quite powerful. And so our CTDI vol values in the body greater than 80 milligray acceptable. Here's an example of a patient, large patient, and with some metal implants in the spine, imaged with the CTDI vol on the body phantom of 99.6 milligray. Image quality looks pretty good, but is this appropriate? Is this reasonable? I don't know the answer to that, but it's definitely something to consider. And this is what the system ended up doing. Another important thing to consider, some final topics, is that there are definitely some scans that automatic exposure control and tube current modulation should not be used on. Perfusion studies in the head are definitely one of those. That's a fixed technique. Make sure that nothing goes too high a dose and we don't get over irradiations. Extremity studies, it probably makes sense not to use all aspects of tube current modulation on. As an example, here's a localizer for an extremity study. I don't know what the tube current modulation system is going to do with this localizer. It's going to really increase it here, which might make sense, and then bring it down here. So maybe some longitudinal tube current modulation might make sense, but probably not axial tube current modulation in this case, especially since down here you're dealing with a circularly symmetric object. So that's something to keep in mind too, how you implement it on extremities. Again, some vendors recommend doing your standard non-contrast head CT, not using tube current modulation. Some will let you use it. I think that's really an institutional experience desire. As I mentioned before, some institutions really do recommend using tube current modulation on pediatric patients. Some say no, it's not a good idea. Use a fixed technique. So these are all, again, open questions, practice dependent, vendor dependent, and radiologist preference dependent. So, thank you.
Okay, do we have any questions? We blow everybody away with all that stuff? Yes.
I have a few comments. First of all, the comment pertains to the display of AEC settings on the PACS. Our PACS, which is an ACFA PACS, does display noise index levels.
Okay.
It was not the easiest thing to do in the world. You have to figure out what's the DICOM structured ID for that. Then you have to go to your PACS and write to them and talk to them several times to convince them who have no physics or clinical background that is important to be displayed, and it will happen. If it can happen in our ACFA PACS, which we don't regard very highly, it can happen for you also. Okay, so that was one. The second thing was that about the SCOUT, the centering of the localizer radiograph. I completely agree with you that that's extremely important to set it right. But when you have a case where you're doing a multi-body region exam like chest and abdomen, always remember that chest can be scanned, should be scanned at a lower dose. Lower dose does not affect chest as much as it's going to affect abdomen, right? So if it's a decision which part to center, it should always be the abdomen and not the chest, which has to be centered, right? So that's just a comment. Thank you.
Thank you.
Karen.
Yeah, I had to. When you scan the pelvic part of that phantom, did your graphic prescription continue on down, or did you strictly prescribe down there where there was no SCOUT?
Prescribed where there was no SCOUT.
Okay. So when you prescribe when there's no SCOUT, yes, it uses the minimum MA. However, if you continue on off of the SCOUT, the system uses the last known MA rotation.
Okay. That was true for the GE, and the Siemens, I think, as well used the last known location. So actually, yeah, it might just have been coincidence that the last known location was what I had set the minimum to. So that's probably why I interpret that. Thank you.
I have a question about the GE. So when the radiologist sets the noise index, who sets the maximum MA? Is the scanner automatically does it, or we randomly select a maximum MA?
Well, there are default protocols that come with the systems, and a maximum MA will be set with that. But it's certainly, especially when commissioning a new system or in your annual review of protocols, it's very important, I think, for the physicist and the radiologist, especially the radiologist, the division heads, to sit down and say, what makes sense for the maximum tube current for this, or for the minimum tube current. I mean, the example that I showed of changing the mass per slice and the noise index on those systems was really a low cost in time effort. It was going to this, talking with the division head, saying, we're a little high, do you want to try adjusting these? And we changed it on one scanner and brought it down. And so these kind of incremental changes, to the best of my understanding, these are quality improvement, image quality improvement things. It's not something, and every institution may vary, so don't quote me on this, but it shouldn't be something you need an IRB to do or informed consent. It's a quality improvement thing. So you can go through with the radiologist, and maybe the technologist who sees how often things are minning or maxing out, go through and make incremental adjustments to find the sweet spot for what the system can do and what your radiologists want. And it's really a low low-cost system to do to really optimize some of these protocols. And you can see, mean differences of, easily 3 milligray, which can add up over the population if you subscribe to that kind of stuff.
So I have a second question. So for example, we set up a maximum MA and we want a specific noise index, and the patient is very obese, and the system from the SCOUT cannot maintain that noise index for the maximum MA. Does it give an error, or it just still scans at the maximum MA?
Scans at the maximum.
Okay, thank you.
Yeah, and we've kind of gone back and forth with that max MA value at my institution. The applications person initially started out convincing me to let it go to whatever maximum it was able to, and I was having a weak moment and went along with that, and then it just happened to stumble across a few wickedly high values on some very large and perfectly round patients who were really we got beautiful images of fat, and there was like nothing else in there. And so using that example, I was able to convince the radiologist to set a max value quite a bit lower than that. And over the course of time, we ran into more and more large patients with inferior image quality, and we're starting to get a lot of complaints about that. And so we've slowly started to push that back up. So you may see that kind of activity at your own place, that for the larger patients, you may need to do things a little differently than the medium and small patients. And for our routine settings now, we've got kind of two groups, the small and average, and sort of large, and then the large patients. And we use different noise index values and different min and max values for those two size groups for all of our adults. So that's kind of how we've decided to deal with it. Okay, if you have any more questions for Mark, you can nail him at the break. We're going to go out in the courtyard again, get a little bit of sunshine, and be back here right at